This podcast does not provide legal. This podcast does not provide medical nor legal advice. Please listen to the complete disclosure at the end of the recording.
Hello, possums, and welcome to Everyone Dies, the podcast where we talk about serious illness, dying, death, and bereavement. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 45 years to help answer your questions about what happens at the end of life.
And I'm Charlie Navarrete, an actor in New York City, and here to offer an every-person viewpoint to our podcast. We are both here because we believe that the more you know, the better prepared you are to make difficult end-of-life decisions.
So, welcome to this week's show. Please relax, get yourself a cup of tea and some cake, and thank you for spending the next hour with Charlie and me for our discussion about decision-making. In the first half, Charlie explores people's interactions with deceased family members in their dreams. In the second half, I'm going to talk about how we know if our loved ones have decision-making ability, capacity, and competency, and what each of those words mean in the legal world. And in the third half, Charlie has some words of encouragement for caregivers from a hospice nurse. So, I don't know if you know this, Charlie, but my favorite cookie is peanut butter with a Hershey Kiss on top. I just love those. So my girls are really great at baking these cookies because I would ask them to make them for me while I was working on a grant or a lesson plan or whatever. But I have found a recipe that uses cake mix, and you just add peanut butter, eggs, and butter. And that's like pretty easy, right?
Yeah.
They take less than an hour to make, and if you keep cake mix and peanut butter in your pantry, you will always have a dessert to take to your next funeral lunch. So check out that recipe, Charlie.
I will.
I know you like to bake.
Yeah. Oh, yeah. That's my middle name, Bake. Sometimes I feel baked. So
well, that has a whole other connotation.
Yes, it does.
So, how's your week been?
Not too bad. It's some days busier than others. Actually that's been it. Some days just very, very quiet, and then making up for it the next day, just juggling several things. How about you?
I'm trying to think like what I've done in the last week, and I don't know. Oh, I had cataract surgery. I took up
That's
a little
right.
bit of time.
Yes.
But I am thrilled to report that I'm thrilled. I can see without glasses. I bought really cute sunglasses. I'm like, this is great.
It's summertime and the living is easy.
I'm telling you, I didn't know what I couldn't see until I got the cataracts. It's like, oh, look what I can do, or look what I can read, or, it's great.
Good.
It's like a new lease on life.
Ah.
So what do you got for us this week, Charles?
Well, cable news network, CNN, reporter Ashley Williams reports that the connections people experience with their loved ones don't necessarily end after death. That many Americans say they've interacted with deceased family members in dreams. This is from a recent Pew Research Center survey. Just over half of 5,079 surveyed adults, 53%, reported having been visited by a dead relative in dreams or some other form. 44% said they've experienced at least one of the following three encounters in the past year: feeling a dead relative's presence, telling a late family member about their lives, or having a deceased relative communicate with them. The Pew survey included responses from Americans of all religious backgrounds, including Buddhists, Jews, and Muslims. The results showed that moderately religious people, measured partly by how often they attend religious services and whether they said they prayed daily, were more likely to have experienced interactions with dead relatives. That is partly because some of the most traditionally religious groups and some of the least religious people, like atheists, are less likely to report interactions with deceased family members. When it comes to religion, about half or more of Catholics, members of the historically Black Protestant tradition, and mainline Protestants say they have had at least one of these three experiences in the last year, significantly more than the 35% of evangelical Protestants who say the same. This from researchers Patricia Tevington and Manolo Corici. Women, 41%, were also more likely than men, 27%, to report recently feeling the presence of a dead relative. Stephanie Pappas of Live Science reports that in their last minutes of life, some people's brains generate a surge of surprisingly organized-looking electrical activity that may reflect consciousness, although, again, scientists aren't entirely sure. New research published in May in the journal PNAS states this surge can sometimes occur after a person stops breathing, but before the brain stops functioning. These otherworldly experiences reported by people who have had close brushes with death are a sense of looking at the body from the outside, a tunnel and white light, or a sense of reliving important memories. Some people who are brought back from the brink of death report seeing or hearing unexplained things during resuscitation or when they seem to be unconscious. The reason for these near-death experiences is unknown, and it's not clear if they're even specific to death. Neuroscientist Chimo Borjajan and her colleagues measured electrical activity in the brains of rats that they euthanized via cardiac arrest. They found that for about 30 seconds after the heart stopped, the brain showed a surge in what are called gamma waves, but again, don't necessarily prove that someone is conscious. Regardless, many Americans report interacting with dead relatives in dreams or other ways, which tells us what? That somebody died and came back to life? I'm glad you asked. Remember that around half of U.S. adults say they've been visited by a dead family member in a dream or some other form, and that a substantial share says they've had interactions with dead relatives in the past 12 months, meaning they felt the presence of a dead relative. A few examples of people who've clinically died and been resuscitated are revealing what they felt and saw moments after their death comes from Victoria Villamanos of BuzzFeed. She states that something everyone faces in life, regardless of class, culture, or creed, is death. And despite its inevitability, the experience of death and what happens after remains unknown to us. People who have died and been resuscitated were asked, "What was your experience? Did you see bright lights? Nothing? Do you remember anything about it?" In response, here are a few descriptions from people who described how they died and what their experience was like. Number 1, a very warm blackness. It wasn't cold or scary, but very calm and serene. It was the best nap I've ever had. 5 out of 5 stars. I'm not in a hurry to do it again, but certainly not scared to die when the time comes. Now, the heart surgery I had after being resuscitated, that was painful and awful. I do not recommend heart failure. 0 out of 5 stars. Next, my husband was on life support in a coma. He was not expected to make it and had to be brought back multiple times. I was by his side, beyond distraught. He was by far the sickest person in the ICU, too sick to transfer to another hospital. Other people who had family in the ICU rallied around to support me, as it really didn't look hopeful for him, and my pain was obvious. One family helped me a lot. The grandfather of that family had had surgery on his foot, but it had gone wrong. They ended up amputating his foot, which then got infected. He ended up dying. But even after he died, his daughter stayed in the ICU to help me. When my husband finally woke up, He told me he had been walking the halls with some guy who was missing his foot. That guy told him it wasn't time to go yet and that his daughter would wait with me until my husband woke up. But he had to wake up soon.
Hmm.
Yeah. And our last comments. I was killed in a head-on with a semi-truck. Reality turned into vibration and I was sucked out of the back of my skull. I found myself in a void, completely comfortable and at peace, knowing full well I was dead. I went through a bit of my life review where a lot of things flashed through my mind. Afterward, I saw the light. However, the light was my phone on the floor of my truck, as that's what my eyes were seeing from my slumped over corpse. I then had a thought that I wanted to get to the phone to say goodbye to my wife and kids. As I had thought, I was pulled back into my body. I'm an atheist, so this whole experience was a bit of a mind fuck for me. I expected nothingness upon death, which is exactly what I got, but I was still unexpectedly conscious. Either way, I've been in pain for 8 years straight now for having pulled through. I'll just embrace death next time.
Hmm.
There we are. Marianne,
Wow.
have you had any experiences like this?
What, dying?
Well, perhaps dying. Hopefully not. But
No,
I mean,
no, I haven't died.
Just family member, friend, Romans,
Well,
countrymen.
Yeah, my sisters visit me all the time.
Mm-hmm.
Occasionally, my mother will show up. Like I have a really good friend, Kathy, who died, I don't know, 10 years ago. She hasn't showed up. I don't know where she is. But like my sisters will come pretty regularly and will, eat and make crafts and talk.
That's interesting because I've seen my mother, my father, Michael, and no one talks to me. They are doing things. There was a very nice one it was Michael and my mother. It was some little village. They were enjoying each other's company. They were just hanging around. I didn't feel unwelcome. It was like I was looking through a window, for example, and just seeing what was happening. They were enjoying themselves. But yeah, I've actually that's not true. There was one time. Remember my first true love, Debbie, back in God, ages ago now.
Yeah, back in the 80s.
When did she die? Yes, it was back. Yeah, 89. Yeah, Indiana Jones and the Last Crusade, 1989. Yes.
You remember life events based on when movies come out?
No, she was a huge fan of Indiana Jones, and she was going quickly, toward the end. And I remember saying to her, well, you know what, if you could hang around, it was something like 3 more weeks. If you could hang around about, I didn't want her to die. I said, if you can hang around about 3 more weeks, we can go see Indiana Jones and the Last Crusade. Remember, Sean Connery is in it. And she said she didn't think she'd be able to hold on. And she didn't. And I don't know, about a year later, maybe a year and a half, I had met someone else. We were in bed together, asleep, and that's when Debbie showed up.
Ooh.
She was fine. She was calm. She was looking at me. There was nothing. I'm the one who freaked out because and this Marianne, this was crazy. So I'm lying there, and in the middle of sleep. Debbie is there in this beautiful white linen dress in her favorite chair.
Oh, the one that I have?
Oh my God, that's right. Yes. Oh my, that's right. You still have it. Yes.
I still have it.
Yes, that chair in the zoo. That was her
The
favorite place.
zoo?
She loved the
Oh,
zoo. She loved the zoo.
wow.
In the zoo, just beaming and looking at me and smiling and said hi. And I was so freaked out because this is crazy. It was in a dream, but the subconscious of my dream, if you will, was thinking, oh my God, I'm in bed with another woman. I know this is really bizarre. And unfortunately, that's what I kept thinking. And it's like, oh my God, she's going to get really upset. I'm here in bed with another woman, not thinking, okay, she's dead, Charlie. Um, Unfortunately, it only lasted a few seconds because
Hmm.
I couldn't embrace it. I don't know why. My thought just went to, this is going to hurt her because I'm in bed with another woman. And poof.
Did she ever come back?
No, not that I'm conscious
Hmm.
of. No, I think she has sporadically, only because of the vibes. I
Hmm.
can't describe it any other way. I don't remember actually seeing her, but seeing someone or some situation. And I kept thinking, this is Debbie.
Hmm.
So that's been it. That's the only time I remember someone addressing me directly. Every other time it's just, and like I said, it's been mostly my mom and dad and Michael, just they're doing something. Um,
Hmm.
and and it's nice. They're just getting along well. So that's it.
Yeah, I like when they come and visit.
Yeah. Mm. So with that, folks, please go to our webpage for this week's recipe for peanut butter with a Hershey kiss on top. And if that weren't enough, additional resources for this program. Your tax-deductible donations are always welcome so that we can continue to offer you quality programming. Thank you in advance for making your donation at www.everyonedies.org. That's every, the number one, dies.org. Marianne?
So, Charlie, I'm going to talk about capacity and competency today. And if you have questions, just let me know. I think that, we all have families. And so I think because of that, it's important to understand the difference between capacity and competency when considering the decision-making ability of our loved ones. We want to be able to make our own decisions for as long as we can do so. And we want that for those that we love and that we care for. But I've seen families and healthcare practitioners disagree with decisions that patients make. But just because we disagree is not enough to say that they can't make the decision at hand. So I've, been in situations where, the patient says, I want to go home. And the physician says, you can't go home. It's, you need somebody to do this, or you need somebody to do that to help you. And the patient says, no, I want to go home. I want to be discharged. So we would, get psyched up to talk to the patient to see if, they have decision-making capacity. And I'm going to tell you the difference between all of these. But to see if he has decision-making capacity in order to say he can make decisions on his own. He understands. And, this patient that I'm talking about, the psychiatrist said, yes, he can make his own decisions. And the doctor was really upset. And the doctor said, but it's not a good decision. He needs to stay here. And I just looked at the doctor and I said, so who protects you from your bad decisions? I know you make bad decisions. I know I make bad decisions. Who protects us? Or do we just get to make bad decisions? He says, well, we get to make bad decisions. I said, right, so does he. We don't have to agree. As long as he's got decision-making capacity, then he can make those decisions. So we all have the right to make bad decisions. And our protective nature wants to protect those we love from making them. But we need to remind ourselves that of all the bad decisions we have made along the way, we've survived. Bad decisions are our right. We have capacity, we have competency. So let's look at what those words mean so that we can understand them and use them correctly. They do not have interchangeable meanings. And I've heard people say, capacity, competency, as though they're the same thing. And, I'm a bit of an English Nazi in terms of, let's use our words correctly, say what you mean what you say,
Yeah.
So I'm going to go through that with you so that all of the listeners and you too, Charlie, will be able to use these words correctly and also help people that you love in the way that they need. So decision-making capacity implies the ability to understand and make medical decisions for oneself. So capacity is the ability to understand and make your own decisions. Now, any physician can usually determine it. It does not require a psychiatrist or court ruling. For a patient to have decision-making capacity, he or she must be able to understand the information, use it in rational ways to come to a decision, appreciate the consequences of the decision, and have that be a reasonable decision for them. So if that patient wants to go home, the interview would go like this. They would say, well, what is it that you want to do? Why is it that you want to do it? Do you tell me about the disease that you have? How does that disease impact your being able to go home? What other options do you have? Because capacity, making decisions, you need to be able to say, are there other options for you? And, have a rational way to come to the decision. That's my home. That's where I've always lived. I've always thought that if I'm going to die, or, because people always think it's an if and not a when, when I'm going to die, that's where I want to do it. And I know that if I go home, that I'm in a weakened state, and yes, that I could fall, and that I live in a rural area, that it could take a while for anybody to come and find me. But I understand that. I'm willing to take that risk. And for me, that's a reasonable decision. So that's what they're looking for. The doctor, the psychiatrist, that's what they're looking for. Do you understand? So another example, you can consider a man who refuses an amputation of a gangrenous leg. He needs to demonstrate that he understands the information about the condition and the options for care, that he could die if it's not amputated, and that this is a rational decision for him. The patient can meet the criteria for decision-making capacity for a particular treatment. So this is called decision-specific capacity. So all decisions are not equal. In healthcare, all decisions are not equal. And so there are some decisions even people with Alzheimer's disease can make, because in the decision-specific capacity, they're able and competent in that particular decision. So you can have decision capacity for a particular treatment and yet not be competent to handle their own practical, financial, and legal affairs. Also, decision-making capacity can vary depending on the treatment decision. When patients lack the capacity to express their own values and preferences for medical care, goals have to be determined by others. For patients who lack decision-making capacity, a proxy decision maker should be sought to help clarify the patient's goals and consent to specific care plans. Generally, the appropriate proxy is a person selected in advance for this role by the patient, or a person who has knowledge of the patient's values and preferences and is willing and able to serve in this capacity. Now, for children, this role usually falls to the parents. For adults, when the patient has not pre-selected a proxy decision maker, this usually falls to the next of kin. Legal criteria for proxy selection will vary from state to state, but each state will have sort of a list of who's first, who's second, who's third in terms of proxy decision making. You don't get to pick in that situation. If you don't, take care of this and do it yourself, they'll go according to the list. So together, these allow an assessment of what the patient would have judged, and this is called substituted judgment. Use of the patient's values and preferences to determine goals of care and treatment priorities will safeguard the best outcome given the circumstances. This process demonstrates respect for the patient and builds trust with healthcare practitioners and teams, knowing that they're acting in the best interest of the patient. Focusing on the wishes of the patient reduces guilt or decision regret for the proxy, family members, and the healthcare practitioner team. Now, in the past, the term incompetent was used to describe persons with diminished mental abilities. The term is rarely used by professionals anymore because it's stigmatizing and it implies deficits that have little to or practical meaning or application. As more is learned about mental function and greater attention is paid to preserving individual rights, greater emphasis is placed on identifying specific mental tasks and skills people retain and lose. Describing a person's ability or capacity to perform tasks, such as remembering to pay bills or calculating how much change is owned, is more useful and meaningful way of looking at mental disability. Understanding mental capacity can help you meet your vulnerable loved one's needs while avoiding unnecessary, restricting, or pushing interventions. So, what is mental capacity? Mental capacity is the ability to make decisions for yourself. People who cannot do this are said to lack capacity. So to have capacity, a person must be able to, 1, understand the information that is relevant to the decision they want to make. 2, retain the information long enough to be able to make the decision. 3, weigh the information available to make the decision. And 4, communicate their decision by any possible means, including talking, sign language, through simple muscle movements such as blinking an eye or squeezing a hand. So, you know how you see in movies, or maybe if you experience yourself, blink twice for yes, or blink once for no, or squeeze, people can communicate in terms of a yes and no way. So people should be assumed to have capacity unless there's clear evidence that shows otherwise. When capacity is in question, the person should be assessed by a suitably qualified professional on whether they can make a particular decision at a particular time. Now, mental capacity is affected by many factors. As people age, they may experience some natural decline in certain mental functions, particularly memory. Pronounced decline, however, signals illness or disease. A variety of factors, some of which are treatable, may contribute to mental decline. They include poor nutrition, depression, and interactions between medications. It's important to know that mental capacity of a person can fluctuate. The time of day may also be a factor for some people. Some people are more alert at certain times of day than at others. For example, a person with dementia might have times of the day when they're able to think more clearly. When a person has fluctuating capacity, they should, wherever possible, be assisted to make the decision at the time that they have the capacity to do so. So if mom is clearest in the morning and there needs to be a decision, let's say about, do not resuscitate order. You can say, Mom, we need to decide this. And you can tell her simply what it is, and if she's nonverbal, you could say, squeeze my hand twice if you want resuscitation. They can make that decision. If they can squeeze and answer and say, here's what I want, here's what I don't want. So what is consent? Consent is when someone accepts or agrees to something that somebody else proposes. For consent to be legal and proper, the person consenting needs to have sufficient mental capacity to understand the implications and ramifications of their actions. So you can see where, capacity comes in terms of how does it apply to, are you willing to have the cataract surgery? Can you give consent to do that? Do you want to do that? Is that important to you? Or no, I'm not going to do that. So that's that consent piece. Here's what it is. Here's what they're going to do. Here's what'll be better for you if you do that. And so what do you think? You want to do that? Now, sometimes people will consent to things not because they want to, but because they're under undue influence. So in recent years, the subject of undue influence has received increasing attention in the field of elder abuse prevention. Simply stated, undue influence is when an individual who is stronger or more powerful gets a weaker individual to do something that the weaker person would not have done otherwise. The stronger person uses various techniques or manipulations over time to gain power and compliance. They may isolate the weaker person, promote dependency, or induce fear and distrust of others. Because undue influence, like mental capacity, raises the question of whether an individual is acting freely, the two concepts are often confused. Although diminished mental capacity may contribute to a person's vulnerability to undue influence, the two are different. And cognitive assessments, thinking assessments, cannot identify the presence of undue influence. Typically, courts make decisions of whether undue influence has been exercised. In doing so, they consider a variety of factors, including whether the transaction took place at an appropriate time and in an appropriate setting, and whether the older person was pressured into acting quickly or discouraged from seeking advice from others. Courts also consider the relationship between the parties and the fairness of the transaction. So if you've got an older adult in your family and you've got somebody in the family who says, hey, let's go to the ATM and get some money, and mom goes along and gives the PIN because they're happy that somebody's come to visit them, or they're afraid that this person's going to hurt them, or they're afraid this person's going to steal from them. They might say, yeah, okay, let's go, because they don't want something bad to happen. But if it were a different situation, they would never consent to going and doing that. A patient will lack capacity to consent to a particular intervention if they're, one, unable to comprehend and retain information related to the decision, especially about the consequences of having or not having the intervention in question. So, if you've got somebody who you say, well, you have bad cataracts, we should have cataract surgery, and the person says, oh, I need surgery, is it on my feet? They have to understand and retain it and process it to be able to say, oh, you want to do surgery on my eye because I can't see. So they have to be able to hold on to that information. And second, if they're unable to use and weigh this information in the decision-making process. Now, before making a judgment that a patient lacks capacity, you must take all steps reasonable in the circumstances to assist the patient in making their own decisions. Now, if the person is unconscious, then that doesn't count. I mean, you're not going to take all the steps possible because they're unconscious. This may involve explaining what is involved in very simple language, using pictures in communication and decision aids as appropriate. You or others are close to your loved one may often be able to help, as well as specialists like speech and language therapists or learning disabilities team, and independent advocates are supportive. So capacity is decision specific. A patient may lack capacity to take a particular complex decision, but be quite able to make other more straightforward decisions or parts of decisions. And I realize that there's a lot that I'm saying in here, but really take a look at the show notes because that will help. And if you need to listen twice, I wouldn't blame you because this can be a little complicated. So there is something called best interests. A patient's best interests are not limited to their medical interests. Other factors which form part of the best interest decision include the wishes and beliefs of the patient when they were competent. So you look and you say, if mom were still competent, would she have agreed to the cataract surgery? And if the answer was yes, and now she's kind of having trouble thinking about like where are cataracts and what does that have to do with anything, then you can use that. So think back to when they were competent. What would they say? Then you take into consideration their current wishes, their general well-being, their spiritual and religious welfare. So two incapacitated patients whose physical condition is identical, which is kind of unlikely, but let's just say that could happen, may therefore have different best interests. Unless your loved one has clearly indicated that certain people should not be involved in their care, or unless the urgency of their situation prevents it, you should attempt to involve people who are close to your loved one, their spouse, their partner, their family and friends, people who are caring for them, supporters or advocates in the decision-making process. They may know your loved one in a way different than you do, and therefore are likely to be able to provide valuable information about your loved one's wishes and values. People may have a living will or an advance directive, specifying how they would like to be treated in the case of future incapacity. And that's what an advance directive is that I am now capable, I now have capacity to make a decision, and I am making a determination in the case of future incapacity. The law is clear that an advance refusal of treatment, which is valid and applicable to later situations in which the patient lacks capacity, is legally binding. So if you've made a decision and you've written it in your living will or your advance directive, and then in the future you'd lack capacity, by law, what you have written is legally binding. An advance refusal is valid if made voluntarily by an appropriately informed person with capacity. Failure to respect such an advance refusal can result in legal action against the practitioner. Now, if there is doubt about the validity of the advance refusal, a ruling should be sought from the court. It's not legally necessary for the refusal to be made in writing or formally witnessed, although such measures add evidentiary weight to the validity of the refusal. A healthcare professional may not override a valid and applicable advance refusal on the grounds of the professional's personal conscientious objection to such a refusal. So what that means is that if you've written it down or if you've said it, the healthcare practitioners who are caring for you, doesn't matter what they think. You've made your decision and they have to abide by it. Although the issue has not yet come before court, it's been suggested that as a matter of public policy, individuals should not be able to refuse advanced measures that are essential to keep a patient comfortable. This is sometimes referred to as basic or essential care and includes keeping the patient warm and clean, free from distressing symptoms such as breathlessness, vomiting, and severe pain. However, some patients may prefer to tolerate some discomfort if this means that they can remain more alert and able to respond to family and friends. Basic essential care would include the offer of oral nutrition and hydration, but it would not cover force feeding an individual or the use of artificial nutrition and hydration. And remember from past podcasts, we've talked about artificial nutrition and hydration is anything that the person is not swallowing by mouth, because that's how we eat. And if they're able to take it in and swallow it, then and they want it, that's cool. But you can't force feed them. And if they don't want it, you don't force artificial nutrition and hydration. The courts have recognized that a competent individual has the right to choose to go on a hunger strike, although this may be qualified if the person has a mental disorder. Toward the end of such a period, an individual is likely to lose capacity or become incompetent. And the courts have stated that if the individual has, while competent, expressed the desire to refuse food until death supervenes, the person cannot be force-fed or fed artificially when incompetent. Now, there may be a conflict between acting as a loved one's advocate and acting what one believes to be in the client's best interest. So here are 4 factors to consider that are helpful in assessing the client's or the patient's capacity. 1, whether the client can communicate reasoning behind decisions consistent with the goals that they've identified. Like if they say, I don't want artificial food and fluids because if, God calls me, I'm going to go and I don't want you to delay it by giving me artificial food and fluids. 2nd, the degree of alertness of a client's state of mind and the ability to understand the relevant information. And how you know they understand it is if they're able to then tell you, what does it mean if we don't put this tube down you and feed you through that tube? Whether the patient can understand the nature of their situation and the consequences of their decisions. If we don't put this tube down you, you're going to die. But the reality is, if we put the tube down you, you're still going to die at some point. And maybe sooner, because you could aspirate that stuff that's in that tube can kind of come up and go in the lungs and you can get pneumonia. So there's that. And 4, whether the patient's decisions are consistent with their lifetime decisions and basic values. So that consistency over time. And, not that any of us are necessarily consistent, but, people are able to predict certain things about our behavior. So, in summary, regarding capacity, sometimes called clinical capacity, this is assessed by a healthcare practitioner, not a judge. It's a clinical opinion regarding the patient's decisional abilities to make healthcare decision. The assessment is based primarily on the person's capacity to understand and inform consent discussion. So what are the elements of informed consent? Knowing what the procedure is, what the risks and benefits are, and are there alternatives? That it's voluntary, that you're competent to make that decision. To engage in informed consent process, people must have the required ability to understand information, to think about the options presented, to evaluate risks and consequences, and to communicate decisions. Every adult is presumed to have capacity and decisional authority unless proven differently. Although frequently used interchangeably, capacity is distinguished from competence, which is a legal term, and the status of which is determined by a court. Determination of decisional capacity within healthcare is an assessment provided by healthcare practitioners. So one thing that I always would tell people with a diagnosis of Alzheimer's disease, those early stages, is that you need to go do your advance directive, do your will, do all those things while you are competent. Because what I've seen is that people who don't do that, and then the person, as the disease progresses, is no longer competent, the only way that you can then be made a decision maker is to go before a judge. And I've seen these hearings, and they are really, truly heartbreaking because you've got the older adult there with their dementing illness, you've got family there, and the family, either the wife or the children, has to say, my dad's not competent anymore. My dad's doing this, my dad's doing that. And the judge has to make a decision. And as a family member, it's really, really hard to stand there and say those kinds of things about your parent. So avoid that. You don't have to go through that. You can make all those decisions ahead of time while you're still considered to have competency, while you're still considered to have capacity to choose. And then nobody has to go through that. So competency, remember, is a judicial determination of legal status. It's made by a judge, not a physician. It is a person's legal ability or inability to make decisions. And there are multiple areas of competency that have to be addressed in legal settings, such as competency to stand trial, to be executed, to be a parent, to make a will, to sign a contract, to make healthcare decisions. Judges who make final decisions about competency, sometimes after input from psychiatrists and psychologists or other healthcare decision makers, but the judge has the final decision. Court opinions about competency should generally be left to the psychiatrist with specific training in forensic psychiatry, except for competency to make healthcare decisions. Finally, guardianship. After a judicial hearing, rights may be removed from a person, which then they're called the ward. If the person is judged incompetent and assigned to another person, the guardian. Guardianship orders are individualized. A person may retain the right to make certain decisions, and other decision-making rights may be assigned to the guardian. To find out which decision-making powers are assigned by the court to the guardian, the specific guardianship order must be reviewed. You look at that and it'll say they can't make decisions about money, but they can, or whatever it is. Medical decision-making may or may not be one of the decision-making powers removed from a ward and assigned to a guardian. So it all depends on that determination by the judge. And any of us could be in the position of having to make these decisions, of being determined if we're competent, to be determined if we have capacity, and some gentleness and kindness in doing that is important. I've too many times see people come running into the ICU, waving their the paperwork, the durable power of attorney, and saying, I'm here and I'm the one who can make decisions. And, the patient could be in the ICU, but that doesn't mean that they can't make their own decisions. And so we have to educate the person waving that paper and say, you only get to do that if they can't make their own decisions. And right now, they can make their own decisions. So I found this really short little poem about parents growing old. And it says, let them grow old with the same love that they let you grow. Let them speak and tell repeated stories with the same patience and interest that they heard yours as a child. Let them overcome like so many times when they let you win. Let them enjoy their friends just as they let you. Let them enjoy the talks with their grandchildren because they see you in them. Let them enjoy living among the objects that have accompanied them for a long time because they suffer when they feel that you tear pieces of this life away. Let them be wrong, like so many times you've been wrong, but they didn't embarrass you by correcting you. Let them live and try to make them happy the last stretch of the path they have left to go. Give them your hand, just like they gave you their hand when you started your path. So, Charlie, any questions about all of that? I know it's a lot, and you might have to kind of listen to it twice, but
No,
any
I
questions?
have no questions. I do have a couple of thoughts. Yeah,
I can't believe
I
that.
know. Go figure. First, to go back to decision-making capacity. Um, yeah, I've just seen and have heard stories, and there was a big article in the newspaper a couple years ago, which I discussed on the air. There's also just like a doctor's ego, and you are absolutely right. If you have that healthcare proxy, and it is clearly, you stipulate exactly what you want. You have somebody there who will advocate for you, and trust me, folks, make sure you have someone who's not going to buckle under pressure. If you have stated clearly what you want, make sure your proxy is going to go the distance, to speak for you when you can't. But getting back to this thing, even here in New York, you'd think, oh, this is not an issue. There were doctors who were given a proxy, who were given proxies and said, oh, no, 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 this is not, I can save this person, or I can heal this person, and just completely ignoring the proxy. And in New York, it is a legal document. And finally, people started taking doctors and hospitals to court. And
And that's what they needed to do, and to force them.
absolutely. And, it doesn't just happen here, but, in other parts of the country. So, also just please be aware doctors are people too and have their egos. So don't let some doctor pressure you or, your decisions to change because, oh, they can rescue you. So there's that.
And I don't know that it's ego. I think that people
Well, no, I don't
become healthcare practitioners because they want to save people.
I'm not saying it's all ego, but I'm sorry. I've just dealt with enough people, and it was the doctor's ego. And I'm not saying that happens most of the time. No, not at all. I agree with you.
How did you determine that it was ego? I'm curious.
Because this in one situation, I went with a family. Their father, I can't get into too much detail, but I went, and because they wanted one thing for their father, and again there was a proxy, and the doctor said no, and I went and just to listen, and this doctor just kept pushing it. That no, we can try this treatment, we can try that treatment, and the the it was his daughter and her husband. She kept saying, but that's not what my dad wants. We have this document here. I mean that, and the doctor just kept.
And that's so unfair for the family, because then they, when dad does die, they say, oh, maybe, should we have listened to that doctor? Should we have done?
Yeah.
Because there's always that Monday morning quarterbacking going on.
Exactly.
Like, well, maybe I should have done something different. This would have turned out different.
And,
and wouldn't have.
Yeah. And the other thing, too, that you mentioned about, speaking up with my mother, she was it was a couple of years before she died, but she was just in one of her cranky moods.
And, just one of them?
Yeah, well, particularly, it was just that one. And, so I don't know, it was lunch or something. So sitting there eating, and, this man walks in, speaking very rapidly, calls her Maria, not like, like she's, it's just the way he, thankfully I was there. But just the way he said it, like she was just any old person, and just immediately going in. So how are you feeling today? Oh, what are you eating? Is that good? Rattling on. And my mother just kept, eating her salad or sipping her soup, and just nothing. And Marianne, I don't remember if I mentioned this to you. This man said, "Oh, so I see you don't understand what I'm saying." And he looked at me, and goes, "So is she always like this? She just doesn't, um, she basically that she lacks the capacity to understand. Is this like dementia? Because we're gonna have to give her, some medication. He's just going on and on." And I said, "My mother hasn't said a word." He goes, "Yes, well, that's a clear sign of," and he used some big word. And then finally, my mother said, "I'm eating." And this guy was like, "Right. Oh, good. So you understand that you're eating." Marianne, I wanted to slap the,
Oh my God.
he was ready just to start giving her all this medic. And I said, "Okay." And I told him, "You walked in here, didn't introduce yourself. You start speaking to her like she's an old friend, and she's not. And you're interrupting her lunch. You don't say, 'Excuse me,' or anything. She's just pissed off at you right now. She doesn't want to feel like talking to you at all. Do you understand that?" He says, "Well, we need to make sure." I said, "She's pissed off. You didn't even say hello. You didn't introduce yourself. And you're immediately throwing labels on her because she doesn't want to speak to you because you're interrupting her lunch." And he finally backed off. But then, after he left, I checked over at the nurse's station to see what exactly he said. And Marianne, he still put in possibly early signs of dementia. Patient didn't seem to completely understand. Marianne,
And there's no assessment to support him writing that.
right. So they did add, and when I explained all that, they laughed. He goes, "Yeah, he does that a lot." It's like, what? And
Then fire him.
What?
Were you going to put people on medication because he doesn't have good bedside manner?
Yeah. So, then I talked to the director, and that's why, the notes were put in. Because, we really like him. He's been here. I said, "Okay, I don't understand the connection. If he did this with my mother, what do you think he's doing with other people? People can't always speak up for themselves." Thankfully, I was here. It's so yeah. So just like what Marianne was saying, you need to speak up for yourself. You need to advocate, get your things in writing, and you just prepare. Do not wait till it's a crisis situation to start making decisions. And
that's the worst time to make decisions is when you're in a crisis. Just do it ahead of time. We know it's uncomfortable. Yeah. We know it's difficult. We've all been there. Yeah. Just do it. Put it in a drawer. Let people know where it is.
And the other thing. Give copies. Oh, I'm sorry. Go ahead. Yeah. Yeah. And that's it. And the thing about second guessing. With Michael, my son, and longtime listeners know that my son Michael died when he was 21 years old, and thankfully Marianne was there for me because Michael was immediately put on life support. He had been shot, and I kept asking Marianne, it's like, "Okay, but you know what? I saw a little twitch in his hand." So maybe there's something there. I don't want to, pull the plug too soon. And Marianne, being Marianne, was very kind and soothing, and in this very difficult time for myself and and for his mother, just gently explained. Well, there's muscle reflexes, and because there's could be some stimulation here from a nerve or something like that. I don't remember exactly, but yeah, thank God you were there. Jeez. Yeah, it was just, well, he would appreciate this. It was just time to pull the plug. Um, so
As horrific
yeah,
as all of that is.
yeah. But the thing with it, and and we talked about this because when my mother died, um, the whole service and everything, like the first thing after the service, Michael said to me, "Okay, I'm not doing this for you. I'm not going through all this. So what do you want?" So I said, "Well, it's up to you, kiddo. This is just you. So whatever you want, I'll be dead." And then I asked him, "What do you want?" He said, "Well, I don't want any machine." And because he was young, I said, "Have you fill out a donor card? You can donate your organs." So I explained to him what that was. I said, it's easy, and they'll put it on your driver's license. He goes, I don't know. It seems like a lot of work to do. And by coincidence, the doctor asked me if I wanted to donate his organs. I said yes. His mother said, absolutely not. I'm not going to cut
Oh
up.
no.
I'm not going to cut up my son. And when the doctor came back again and brought it up, his mother just started, saying, no, you're not cutting him up. To which the doctor said, your son signed a donor card. And I'm thinking it's one of the few times my child actually listened to me.
Isn't that incredible?
Yeah. So there, 8 people are out there with, 8 different organs of my son.
And that's, with the exception of having been shot, all of those organs were prime.
Yes, they were. They were.
And it would have been such a shame to cremate them or bury them.
And then after that, I mean, his mother, thought better and said, she was glad that had happened. She just, understandably, just, beside herself. I was too. So yeah, it's just that even in a situation like that, where obviously Michael could not talk for himself, and we knew even if there would have been a chance to survive, I mean, he would never have wanted to live like that. But the choice was not ours to make, anyways. He was gone, and it was just nice to have, in my case, Marianne, just to simply, walk me through that. So that's the thing, yeah.
And our listeners too can always email us if you've got questions. I've had many people.
Oh, absolutely, yeah.
Get in touch and say, "Here's the situation. What do you think?" So feel free to email us at mail@everyonedies.org, or you can email me, Marianne, MARIANNE @everyonedies.org. Because we know this is hard.
Yeah. Thanks for all that, Marianne.
I'm glad to be there for you, Charles.
Well, I meant not only for me, but just, to let everyone know. I mean, just share your wisdom.
Yeah, I'm going to give them your email next.
Well, first you want to hit your favorite bartender and talk it over with him. Yeah, that's, if you want to go in that direction, feel free to email me. Okay, so we saw this anonymous post on Facebook, and we thought we'd share it with you. You cannot hold this over your head. I've seen these circumstances so frequently. The guilt we put ourselves through is incredible. When someone we love die, it is so common to have mixed emotions, thoughts, questions, and feelings, like you should have or could have done something more or something different. I am a 16-year experienced and certified hospice nurse. I have some thoughts on this topic. Your power of attorney did not activate until they were no longer able to make their own decisions. They were aware of their diagnosis. They were aware of the treatment options, and they oversaw making those decisions throughout the course of their journey. They oversaw coming to the terms of their impending death, and at some point, they did accept it. They knew. Whether they wanted to face it or admit it, that's another question. But only when they were so sick and so beaten down from their disease, incoherent or confused, did you start to take over the decision-making process, and you did the best job you possibly could as a beautiful soul. If you were caring for someone that could never make those decisions for themselves, maybe they weren't aware of their diagnosis, maybe they didn't have any control throughout the process, and all those heavy decisions fell on you. I'm sorry you had to go through that. But who was better for the job? You did everything you possibly could and nothing less. We may not understand why things happened the way they did, in the order that they did, with the outcomes we've endured, but you've made it through. Albeit with heartache and some painful memories, you did exactly what you needed to do. You created beautiful memories through the pain and suffering. You cared for them and showed them the love and compassion they needed, and you never gave up. You are someone who stepped up to the plate when they needed you most, someone to help preserve their dignity, advocate for them, and care for them during arguably the hardest trial of their life. And that, my dear, is admirable. What you did for your friend or loved one was selfless and hard, and you will grow even more from this experience, and you did a beautiful job. Also remember that you did what you could at the time, given the circumstances and resources you had. Who could expect more? You did not purposely fail them. You did not fail them at all. You helped them reach peace at the end of their journey, and you made it through too. Their souls are free, and they had you to help guide them. They are at peace and have no hard feelings for anything that you did or didn't do. How can you heal when you cannot forgive yourself for something you had absolutely no control of? You did a wonderful job. You are a beautiful soul. Thank you for helping them.
That needs to be said. It really needs to be said, because people feel so guilty about, decisions that they've made when really the person themselves made those decisions, and you're just making sure they're carried out.
Yes.
But you carry it around. I've met so many people that say, "Oh, I had to pull the plug on my mother. I had to do." It's like, you didn't. You just did what she asked you to do.
Yes, exactly. Yeah. And that is this week's episode. Please stay tuned for the continuing saga of Everyone Dies, and thank you for listening. This is Charlie Navarrete. And from William Butler Yeats' A Drinking Song, wine comes in at the mouth, and love comes in at the eye. That's all we shall know for truth before we grow old and die.
And I'm Marianne Matzo, and we'll see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.